Welcome everybody to this edition of Alliance Live. Today I'm delighted to be speaking with Derek Barron, Chair of the Review into the Delivery of Forensic Mental Health Services in Scotland. Welcome, Derek. Thanks for joining us.
Thank you for the invite.
So Derek was appointed Chair of the Review by the Minister for Mental Health, but the day job is Director of Care at Erskine, which provides person-centred care for veterans. And Derek was granted special leave from Erskine to act as chair of the review. Prior to Erskine as well, Derek has a long and distinguished career with several NHS boards. So thanks again for joining us, Derek, and I'll just get started.
Okay, I'm looking forward to it. Thank you.
So first of all, could you tell us a little bit about the review and how it came about and what it involved?
Yep, certainly. I think the important thing to set out at the beginning was this is an independent review, not a statutory review, and it didn't come about because of a negative event. Sometimes if there's a negative event, you've got an investigative review. This wasn't like that. This was more about the Minister saying, look, services have developed organically over the last few years. Where has it left us? What are they at? What's happening with them? I guess my interpretation of what the Minister was saying was, you know, are the services still working for the people who they're designed for? Are they working effectively? Where and how are people's human rights protected? Where are their gaps? So that was kind of the background to it. So the Minister announced this, of course, in Parliament in March 2019, and then I was appointed in June of the same year, with the Secretariat support being appointed in July. So it was kind of, once you got it up and running, that was great to do. So the first steps I took with that, along with the Secretariat, was to set up some working groups. We wanted people with expertise. So although you said I've got a long career in mental health, as a mental health nurse myself, I wasn't steeped in forensic, and I think that probably helped bring a different view to how this was going to be. So I wasn't invested in coming to a particular outcome. It was really open. So we got the group set up. That was people who are receiving, or representatives of people receiving services, because obviously they can't often come to these groups, people who deliver the services, and people who are monitoring the services. So as I said, there wasn't a preconceived idea I had of this. It was about listening. What were people saying? So from August 19 to February of 2020, we really went through that listening phase, and then you'll not be surprised that we'll all get interrupted from COVID from March onwards, and that meant we had to pause the review, somewhat optimistically or foolishly, depending on what way you look at it. I thought we'll be able to get back to this in June or July, and we did, thinking COVID would be away by June or July. I'm sure a lot of us had those thoughts at the beginning, but it obviously wasn't. So that was making it more difficult. However, we then got to publish our interim report in August of that year. That was called What People Told Us. We then went back, reviewed those issues, sought feedback on what we had said in that review, and then that helped us feed into what is the final review.
Well, some of our audience might not be so familiar with what's meant by the term forensic mental health services. Could you tell us what these are and who might use them?
Yes, yes and no. Right. One of the, and when you get to read the report, you'll understand that yes and no answer. There's a very narrow definition of forensic, but the more I spent in the last 20 months, the more you came to realise actually there isn't just one definition of forensic. So one of the recommendations is that we need to actually go and define that. So a narrow definition would be that it's a service to assess, care, treat and rehabilitate people who have committed a serious offence as a result of their mental disorder. So that's a very narrow view of it. And that currently includes people with a learning disability. So again, that's something we need to look at. But there's also the role that the services have is about that clinical rehabilitation, but also the risk management and protection of the public. But what we looked at from this was people who come into forensic services that perhaps shouldn't be in forensic services, and we need to support and make sure that doesn't happen. But also people who are being cared for by forensic services, it doesn't come under that narrow definition. That means there's a disequity across the country of who can access forensic services, where you can get that expectation of input, or where you can get that if someone was looking for advice and guidance on it. So one of the recommendations I said is that we should define the purpose of forensic mental health services. Are people falling through the gaps because one area interprets it one way and a different interpretations in the other way? What's its relationship with general mental health services? There's also, as I said, that concern that people might end up in forensic services they really shouldn't be. And while I would love a country where there was no stigma around the word forensic and forensic mental health services, there is. So we don't want to bring people into that system if we can possibly avoid it.
Mm-hmm. And you spoke a wee bit there earlier about the kind of different phases of the review, including that period of sort of the listening phase, so to speak. And you've mentioned a few of the people that you've heard from. Could you tell us a wee bit more about who you've heard from during the course of the review?
Yeah, I thought it at the absolute fundamental that I engaged with people who are receiving services. So as I said earlier in the working groups, they can't come to the working groups, right, because they're in a hospital in a secure setting. So from the outset, I wanted to go and meet with those people who have got lived experience and are currently living that experience. I think that's critically important. I was delighted to see how open people were about wanting to speak to me, about wanting to say, this is my experience. This is, so sometimes it was in groups, sometimes it was one-to-one or one or two people. So over the first period of the review, I went to 11 different hospital settings to meet with people across Scotland, and I met with nearly 300 people during that period of time. People receiving services, advocates, family members, managers and staff. So just round about 100 of people who were receiving services and their families, and the rest were staff working in services. But also, because we'd opened up for written evidence as well, we had, I think it was about 120 people in organisations who responded in writing to us. So it was quite a substantial number of people, as well as the dedicated members of the working groups. And they were, so with representatives of people with lived experience and carers. They then went out to their constituents and said, what do you think? So they could feed in with other people's voices, which was great. We had clinicians, we had managers, people from criminal justice setting, mental welfare commission, and of course third sector colleagues. And one that was important for me was the Scottish Human Rights Commission. I wanted them to have a view of everything we're doing to guide me to say, have you thought about this? Have you thought about that? So that was really important for me to be able to do that. And I did say, and I would like to say thank you to everyone, because their contribution was phenomenal. They gave their time many times when we went back to clarify things, and I'd go back and ask for details of this and details of that, and they gave generously. So I would like to say acknowledge thanks to them.
That's great. Well, it's great to hear that there was such a breadth of people and organisations across the spectrum were able to feed into this work. It's just so important. You had mentioned the interim report that was published in August 2020, and certainly at the end of this, what we'll do is we'll put up a slide with the hyperlink there to the webpage where everybody will be able to access that interim report, as well as the final report that we'll come on and have a bit more of a chat about. But in the meantime, I was wondering, just in regard to that interim report, which is focused on, as you said, what you heard from people were the key, or are the key issues and challenges currently in forensic mental health services in Scotland. Could you tell us a bit about what you did here?
Yes, the interim report was interesting for me, Lucy, because there was two things. One is that what we came across was disappointing, because there were known issues. So that was the kind of downside. The good thing is actually we were capturing the issues. So that was a positive thing about the report. But it was disappointing that we're coming across issues that were known when we came across, when we presented. People say, oh yes, we knew about that, we knew about that. And there's that question of, if everyone knew, then why weren't we doing something about it? And I think when we lead on later on to the final report, what I'll say is that there was no central coordination. There was no one point of, actually, this is who's responsible and this is who's going to make the recommendations work. And I'll be honest, some people thought about this review as well, that is it going to go the same way as other reviews and nothing will happen. So you've got that frustration of people as well. So as well as that disappointment, one of the biggest things I came across was variation, and with that variation, frustration. So there was variation between how services were provided, who they provided them for, how long, what they're in a ward setting, what you're allowed in one ward but not allowed in another ward, how you get into a hospital versus another hospital, and these inconsistencies caused uncertainty and stress for people who were having to go into them and to their families. Am I allowed to visit here? Can I visit? It created a sense of unfairness and inequality, kind of depending on where you live. The concern for me in that was the length of time that people spend in the forensic setting in a hospital. Unlike most other areas, where you go in for a relatively short period of time, a few weeks, a few months or whatever, on average, people are spending 12 or 13 years in the forensic system. We need to get it right. We need to be able to understand someone's journey and start from the outset to say, how do we focus on that person's rehabilitation? How do we, and so that came across very early on. The lack of capacity in the system was startling. So we've got services who are working at 100% most of the time. Now, that just cannot be. You cannot work at 100% all of the time. It leaves you no flexibility, no ability to respond or react or be proactive in things. And the other thing that came across very early on that disappointed me was women's services. So I don't think that it's something we can be proud of as a country not to provide high secure women's services within our country. We are a small country, but we're big enough to provide services here for women rather than having to go down to England and Nottinghamshire for that. I think that disrupts and interrupts their family life, their ability to have people come and visit them and maintain those contacts. So that was a real sense I got early on in the interim report. The other one that came across that had been tried to be dealt with several times is court reports. So you think, well, what's important about court reports? Well, and I'll use the court terminology here, not mine, in terms of disposal of someone. They're a terrible term, but it's their term. They need to understand, does someone need to go to hospital? Does someone need to go to prison? Does someone need something else? Part of that is being able to get reports from the forensic mental health system to say, actually, this is the correct route for this individual to go down. So that was another one. And as I said before, other reports have come up with recommendations and they've not been followed through on. So as I said, that's the overall thing of the interim report.
Well, thanks so much for that. And as I said, we'll come on and look in some detail at one or two of the issues that you've covered in the final report, because unfortunately we just don't have time, much as I would love to be honest with you, go into much more detail on it. But if we do turn to the final report now, so it was published 26th of February this year, 2021, and that contains your recommendations for tackling some of these not just the big issues, but some of the more detailed issues related to, for example, certain population groups. We've already mentioned women, and again, I'm going to come on and ask you some more questions about that. But what I found really interesting was that early on in the report, you set out some key principles. I was just wondering if you could tell us about these and why they're important.
Yes, I think when we go back to the definitions of forensic services, you need to understand what it is you're about. What should be driving you? What should be the pillars upon which you're building the services? So again, I mentioned having the Scottish Human Rights Commissions as part of the working group, because I think human rights are at the basis of what we should be doing as a service. And I was determined that we didn't just bandy the word human rights about, because it's easy to do. Oh, human rights this and human rights that. So I think what we wanted to say it was, so here are the key principles of what you need to do. And then going back to the Milan principles. So we know the Milan principles and how, equality of access, reciprocity, and for those who might not understand reciprocity, they're not embedded in mental health. That's about when society, or in this case, the services, place a burden on you. So in other words, you're going to be restricted in what you're allowed to do. That then places on the organisation and society a duty to provide the services to support you to get well. So I think that we wanted to make sure that that was running through everything we did in relation to the report in terms of receiving care and treatment. Importantly, in the least restrictive way, and when we come on later on, you'll see why I don't think it's always in the least restrictive way, and we need to do something about it. And I've mentioned already rehabilitation as an underpinning principle. It's not just about putting people in a secure setting and keeping them there. We have a duty to support that person into being a productive member of society, to provide them, to support them back into having a life out with the services, to participate in society, to have aims, aspirations, the way you and I would have, whether that's a job or relationship. And to me, the key thing that's run through everything we've done, and what I hope I've done in my career, is about being person-centred in practice, having the individual at the centre of what we're doing and trying to have our services focused round about them.
Fantastic. Well, I'm a big fan of the person-centred, rights-based approach, as you know, so I was absolutely delighted to see those principles front and centre, and I'm sure many people have, and I know, just looking on social media, how welcomed your report has been across the piece, both by people with lived experience, the unpaid carers that were involved, and also members of the different professional groups. So if we start to take a bit more of a look now at some of the recommendations, 67 recommendations set out in key sections throughout the report, covering issues like you've already touched on around things like strategic governance and that oversight, that responsibility, the definition of forensic mental health services, women's pathways, as we've already touched on, certain other specific population groups as well, people with learning difficulties, as we've spoken about, capacity and transitions, and that person-centred approach that you've mentioned, and last but by no means least, sharing information and expertise. So if we can come back to something that you mentioned, I think much earlier on in our conversation, this idea of a new national NHS board responsible for forensic mental health services in Scotland. Tell us a bit more about that recommendation.
I think if I take one step back to the interim report, when I said to you about that variation and frustration, that's almost the basis of this. So there was no central coordination. One person said there was no central brain. There was no one organisation, no one structure, no one that said, we need to do this to wrap it around the individual, so the individual transition and moving through the services is what is best interest for them. So you would have individual groups. You might have a regional group who do things for that region. You might have an individual board. And we came across circumstances where individual boards made individual decisions that worked for them. Right, and you go, well, what about the rest of the system? How do they fit into it? So there wasn't a central point of that. So we looked at, could you have regional commissioning? Could you have regional management? And I felt overall, the more evidence we gathered in this, there actually was only one solution, which is to have one central coordinating NHS board that is responsible for the totality of forensic mental health services. It would support that direction, it would support that commissioning, the communication. It would reduce the number of barriers we have. You know, the number of times people have to go through reassessments simply because it's between boards. You can go, this can't be right. And I've spent half my life in community mental health where the thing was a single shared assessment or reducing the number of assessments, where forensic services, I felt there was too much in the way of bringing this together. It also, the current system leaves too much to people who people know and goodwill of staff, rather than saying, actually, no, this is someone's right to have this. It doesn't depend on me knowing Lucy and be able to say, can you do this and can you do that? It's actually should be, it's a duty for us to wrap around the individual. That clearly links to capacity. So it might be, when we get all the information we need, that we have enough beds, but they're just in the wrong place and at the wrong levels. I suspect it won't. I suspect we still won't have enough beds initially, and we need to do some work in relation to that. So the single board has the operational authority to say, we must do and we must deliver, and importantly, the accountability for that. So they'll be accountable the way that the state hospital board's accountable for its services in high, but Greater Glasgow and Clyde are accountable for its services. But look at the size of that board, and yet forensics is a very small, really important, highly specialist area, but it's very small in terms of the size of what that board has to deliver. So it's no wonder that it perhaps doesn't get the focus that this highly specialist group of individuals need to support that. I also think it will create a transparency in what we're doing, because that board would be accountable to ministers and answerable to the public in what it's going to do. I have made a slight difference in that, and that's people with a learning disability or learning disability services at low, secure and community. I didn't think they should be in forensic services, forensic mental health services, because of the way those services operate in that particular group of people who I think need a different type of support, which is, I think, best delivered from community learning disability teams in terms of the transitions in and out of community and how you support people. And I felt that the community learning disability teams had the skills and knowledge and willingness to do that. So they've not come into this single board, neither has the new young persons unit in Ayrshire and Arran, which is securing it. Although I said we should keep these things under review, let them up and running and see. But again, you don't want it to be an automatic transition from that adolescent secure unit into adult forensic services if we can avoid it. And I was delighted to see that the ethos of that service wasn't to do that, it was to actually support people to go and have a normal life, whatever normal means.
Mm-hmm.
The other thing that you can't really tackle if you've all these various bits and pieces is capacity. People waiting, because you might be waiting over there and you might be waiting over there, but if no one's actually collecting the system-wide information, and I didn't really think we were collecting it systematically. So the forensic network asks people, but the key there is they ask people for information. They don't need to give it, and so that coordination isn't where it should be. I think we've got too many people waiting in conditions of excess security, and we know that the Act changed a few years ago to allow appeals against that, but there's no appeal at low secure. And I'm going, well, that can't be right. So that means you can be stuck at low secure even though you're ready to move to community. And I think, well, we need to look at that. And so I have a recommendation about how we could support that to be an exit from the system, or certainly an exit from the inpatient aspect to support people in community. I think that was kind of fairly key in what we're doing. The one other thing I would have said is about beds and capacity, and Rowan Bank are almost ready to go with building new capacity there. And I felt, well, actually, see from what we already know, even if you built that just now and in 5 years' time we were a little bit over capacity, then that's a good thing, because that allows flexibility, that allows staff development, that allows staff training, that allows, if someone needs to move urgently from one place to another, they can do that and we can be responsive. On 2 of the visits, I did. The staff had to excuse themselves to go and deal with a court phoning them saying, you need to take this person, and in one of the cases, the woman, right now. And then to see the management team and the clinicians all right, what we do. So somebody's going to get moved, even though it might not be right for them, because it's least disruptive to them to bring somebody else in. That can't be right, and that's the problem with a system working at 100%. That flexibility.
There's a lot of really rich information in there, and I would just take this opportunity as well for anybody that is watching this to please do go and read the interim report and the final report. And actually, I think it's interesting that you say, you know, one of the first things you heard was that many people who are involved in the system as it is are saying, oh yeah, we know about that, or we've known about that for quite a while. I would imagine for those not necessarily so au fait with the forensic mental health system in Scotland, a lot of this will be very new and interesting information for them. And a lot of people would say, but that just doesn't seem to make sense. You know, how is it, why does it work that way? Or why are these groups of people involved in this? Doesn't seem like it really, you know, that's the best fit, or that's the best, that's the best that we can do. And one of those population groups, as you've already mentioned, is women. And you've mentioned that what you'd heard from other people, but also your own thoughts on that. And you've made us several recommendations about services for women. Could you tell us a bit more about that?
Yeah, I personally and professionally find it unacceptable that we don't provide high secure services for women in Scotland. Now, the numbers fortunately are low, so I recognise there is a difficulty in how you do it and the cost involved in that. But I don't think if we base our services around human rights, if we base it around the needs of the individual, then cost shouldn't be the preeminent aspect of it. Of course, we need to think about that. We don't have lots of money to waste. However, I don't think it's wasted money looking after women here in Scotland, where we can support them to have their social communities, whatever they've been linked with. Perhaps some have families, perhaps some have children, and we can maintain those contacts. So I think we need to bring that back from England as soon as possible. So the report, the final report, actually says that we should re-establish that at the state hospital. There are options of how you could do that, and there was an option paper done not that long ago which has got suggestions in it. But what I've said is that any other suggestion is going to be many years away, because it would require us building something. So in other words, what you'd have to do is you'd have to get the site, you'd have to plan the site, you'd have to plan the building, you'd have to do your public consultations and then build the building. So you're talking about anywhere between 5 years away. And I just don't think that's acceptable. And I've got to say, most of the people who I came across, in fact, no, all of the people I came across felt it was unacceptable as well. So there has been some not favour of the state hospital. Most people do. But I've said that we should have that service in the state hospital within 9 months of the report being published. Why 9 months? Because I think it's easy to kick these things into the long grass. And if you simply say, oh, we should provide in the state hospital as soon as possible, your as soon as possible and my as soon as possible might differ. So I've set a timescale so that I think it should be done within that. I think that's reasonable. We know the state hospital has spare capacity within it and spare buildings within it. 9 months, because we will need time to train staff. We will need time to make the accommodation suitable for how we're going to do things, because that accommodation has to be suitable for women with a learning disability as well as women with mental health difficulties. And that was a kind of short term, let's get that sorted just now. In the longer term, we need to be clear about women's pathways through the system, whether that's at medium or at low. What is it? How do we provide services for women? Because it felt disjointed for me, not because anybody is doing anything bad or trying to do anything bad. It's simply that there's no central coordination of what we're doing. A lot of people working hard, but sometimes you have to stop the hamster wheel to actually stop what we're doing, how we're doing that. And I think the board's national board structure allows us to do that an awful lot better. So if I was going to say, I would really like to see the new board, and I'd like to see women's services sorted. Not that I'm saying the other 67 or 65 recommendations are not important. They are important to allow us to do all this. But I think surely as a country, we can treat our women fairly in the way we treat men who are in need of these special services.
Mm-hmm. And one of the issues, the other issues that's covered in the report, and I think it's fair to say people who access forensic mental health services certainly expressed mixed experiences of, is the degree to which they're involved in decision making. And you've made some recommendations around this, around participation in decision making. Could you tell us a bit more about those recommendations?
Yep. So I think throughout my career, I've tried to ensure that people have got an input to their care plan, an input to what they want to happen. But in the last 5 years since moving to Erskine, I think care homes take that to a different level. And so that learning and that development I've had here is about how you involve people, the importance of involving people in everything that you do. And so I've just taken both my old NHS experience and how I tried to deliver service and my experience here to say, actually, everyone should be involved in their care and treatment. What are your plans? What are your aspirations? Now, at points in people's journey, they might not have that. They might not have the insight, and that's okay. But that doesn't mean that you just ignore what they're going to say. And the view of families, I think, are important in relation to that. Now, I know people, and I've been a clinician for many years, will say the issue of confidentiality and what you can and can't say. But one of the recommendations is about having a specific person that families can go and ask it. So I remember when I was in Golden Hill in Clydebank, what we would have is a person who not directly related to the care that's going on, that families could come and ask questions to. So you give them general answers about what could happen and options, and to involve them in that care as well. But in terms of complaints, and that we heard from a number of people saying, no, you just keep your head down, otherwise it could go wrong, or just keep your head, it's best not to say anything because they'll just put it down to, oh, they're ill or whatnot. So we have to find a way of supporting people to have their voices heard, and advocacy does a great job in relation to that, but I think there must be more than that. This is a vulnerable population who are detained for a long period of time. We have to recognise that and support, well, how do people get their voices heard without feeling, oh, right, if I say this, they're going to put up my medication, or they're going to say, oh, stop my SUS plan, so the suspension detention to get out plan. So yeah, it's about trying to get back to the best practice that I saw in some areas. It just wasn't always available, and feedback from those with lived experience sometimes felt they were saying, well, I'm not involved, I'm told what's going to happen.
And it speaks to that consistency or inconsistency piece as well, as you're saying. So if it can, if it's working well somewhere, in one bit of the system, how do we make sure that that can be cascaded throughout across the piece? And you'd mentioned family and friends there, unpaid carers, and you've dedicated some recommendations as well to that cohort of people who, as well, had sort of, I think, as demonstrated in the interim report, had expressed mixed experiences about, even just their awareness and understanding of what forensic mental health services are, what it means for their loved ones, what it means for them. And again, as you've pointed out, the piece around involvement in decision making, with, I think, some people saying, there's issues around confidentiality, as you mentioned, but also a seeming unwillingness on the part of some people to really kind of involve them in decisions, or at least call upon them for the expertise and knowledge that they have that could help in this. Can you tell us a bit more about the recommendations you've made about unpaid carers?
It was more about how they are supported. So I've always been a believer in advocacy. whether that's independent advocacy or collective advocacy. I think that they bring a collective view. And I've got to say, some of the advocacy service I saw through Forensic did an exceptional job in representing the views of individuals. Even when the person was there, they would say, no, you tell them what I told you. So that was important. But carers play a phenomenal role in society in general. But also for this group of people who are need highly specialist care. Their families know what's happening. The families see some of the early signs of what might be happening. And I guess one of the disappointments, and I spoke at a conference with carers, and at least two of the families said to me, oh yes, we were told my daughter is not ill enough yet. And you can think, so we're leaving those families looking after someone until they become ill enough, do something that then means they're going to be in a secure setting for a long period of time. And I just, I'm a parent, so I think of it from that point of view. I'm a nurse, I think of it from that point of view as well. And I think we have to be more proactive in engaging families. Now, families will get it wrong. I'm not blind to say that families are always right, but the very least we should do is to listen to their voice and say, right, okay, let's have that discussion. I'm not dismissing it. We might end up disagreeing, but at least if you know that we're listening to you, we can have that dialogue. And in some areas that seemed to go okay. In other areas, it felt like families weren't always welcomed into being part of the extended care team and how you deliver things. So that's the recommendations of trying to focus a little bit on, let's bring this together a little bit more, because if you are person-centered, you're wrapping around the individual, actually I'll take any information that might help in terms of what we're going to do for that person to support rehabilitation. And
of course, we know that it's not about, doesn't have to be about reinventing the wheel. There are tools out there. There's equal partners in care. There's the triangle of care. There's things that can be drawn upon to kind of support that work without having to start, starting from a blank sheet of paper. So that's your report now out. You're freed from your duties as independent chair of the review. Now that report is out, Derek, what do you want to see happen next?
So I said earlier on in this interview that people have said other reviews have come and gone and nothing's happened. I would be disappointed that after 20 months of doing this, and including through a particularly difficult period of time with COVID, that myself and the Secretariat and the working group members and others still came together to put into this. So I'd be disappointed if the recommendations weren't taken forward, but that now sits with the Minister. So the report, as you say, was presented, actually presented to the Minister on the last day of January as per my target, but we published it on the 26th of February, last day of February. So I'd like to see the new board being adopted. I think that is a positive way forward in terms of making sure we're coordinated, having that central planning and having a whole system approach for Scotland for this highly complex specialist needs group of people. I think it would bring greater transparency. I'd like to see that. I'd like to see resourcing round about social care. One of the issues that we had here was people unable to move out of low secure, which actually was the cause of the bottleneck. If we can support people back into community quicker, then we'll free up the beds. Not that I like talking about beds, but we'll free up those spaces that we can then have people in the right level of security, hopefully for a lesser period of time on that transition to be able to do things. Then they can go back to having a life. That will mean us investing in housing. So from a local authority point of view, that will mean us investing in community forensic mental health team, because to allow people to come out, they're still going to need support. If you've been in a structured environment for 12, 13 years, although let's hope that will be less, say even 10 years, to suddenly be in your own flat, on your own house, without that structure, you're still going to need support to do that. So it's not just of toss somebody out and go, right, cheerio, and that's it. It was that ongoing support in relation to that. So the community teams are important. I also think that some national systems, and I didn't really touch on it, but electronic systems, single records, is a way to stop having to repeat things all the time, but also to share that knowledge and that expertise about things. And at the end of it all, if we had a system that was, as I started at the beginning, person-centred, if it was based on human rights and delivered on the human rights principles, if it delivered on reciprocity in terms of that restriction on one person brings responsibility on us, then that'd be great. I'll be hugely disappointed if there was no change. Having spent, I don't get the feeling from the minister that she'd want a review for the sake of a review. I think she wanted a review because she wants something to happen. It's really over to the minister now, so I will watch with interest.
Yes.
My day job.
Yes, and I'm sure there will be many others of us as well, Alliance included, who'll be watching with interest too. So, well, listen, thank you so much, Derek. We know that you're very busy, back at work at Erskine with, as we were talking about before we started recording rather, the reopening of day visiting, which is fantastic news to many people as well. So we know you're really busy and really appreciate you taking the time to speak to us today about the review and your work on that. It's such an important issue of great interest to many Alliance members. So thanks very much indeed.
Okay, and thank you very much, and thanks for the invite. And I hope it's informative for your viewers, and I hope they enjoy reading the report. But as I said, I hope the report gets implemented and as soon as possible.
A great note to finish on. Thank you.
Thank you very much.